Hello, my name is Michelle Pineda. I'm an OMIC risk manager. Today I'm joined by Dr. Chris Albanis. She is the Chief Medical Officer at Ocular Partners. She's a clinical associate at the University of Chicago Department of Ophthalmology, and she's Chair, Advocate Christ Medical Center, Department of Ophthalmology. Thank you, Dr. Albanis, for joining me today. We are going to be discussing lessons learned from cataract surgery. Don't be discouraged by the title. There's actually something for everyone in the cases today. There will be 4 cases. We have no financial disclosures. And the agenda is as follows. We're going to discuss perioperative protocols, including safety checks, informed consent, surgical goals. We're also going to discuss error management, documentation, and telephone screening, including post-op complaints. Case selection and medical facts. All of the cases are actual claims at OMIC that are closed. They were selected to highlight the risk management learning points, and the medical chronologies have been abbreviated. This slide really just shows you the probability of a claim in a 30-year career in practice. We do get asked this, and doctors do find it interesting that there is a probability of a claim in a given year, 8% chance actually, and diagnostic error led to 14% of OMIC claims and 34% of claim payments. This is just a claims history from 2011 to 2020. It shows that of all OMIC claims, so that would include retina, general ophthalmology, oculoplastic, and all of the specialties, 80% of the claims were closed with 0 indemnity payment. What's indemnity payment? That's actually the settlement amount. And an average settlement was $226,101. And then of just the cataract claims, 83% were closed with 0 indemnity payment, which just shows you that, it's really a low frequency. Average settlement, $148,496, with 4 plaintiff verdicts that equal $2.6 million. Before we get started, I'm just going to briefly go over the legal elements of a medical malpractice claim. We call it the 4 Ds. The duty to treat, which of course you put a shingle out, you say, I'm open for business, and that establishes your duty to treat. Deviation from standard of care, which requires expert testimony in your specialty. And the standard would be, what would a reasonably prudent ophthalmologist do in the same or similar circumstances? Then direct causal relationship between the deviation and the alleged injury or damages. We call that the proximate cause. And then, of course, actual damages, which can be economic and non-economic. I'm now going to turn this over to Chris to talk about the first case.
Great. Thanks so much, Michelle, for that great overview. The first case we're going to discuss is about a wrong IOL. So the preoperative evaluation, a 65-year-old presents complaining of blurry vision for 6 months in both eyes. Uncorrected visual acuity was 20/40 in each eye, 3+ NS in both eyes, and the surgical plan was for a multifocal IOL to be placed. And the surgery was performed, starting with the left eye, and no complications were noted. In the operative report, there is a note of phaco and posterior lens. The lens is stated to be a monofocal lens of 25.5 diopters. As we previously discussed, the planned lens was to be a multifocal lens. There are no mention of any complications in the operative note, and the lens order form clearly indicates a multifocal lens was ordered. On postoperative day 1, the patient is seen by the surgeon. The vision is improved, the PCIOL is in good condition and position, and the patient is asked to return per routine in 1 week. later, on chart review, a handwritten note addending that post-op day 1 visit is found. Now, as we get later in the case, we'll find that this note, in fact, was likely not written on the first post-operative day. The note reads that a monofocal lens was inserted into the capsular bag. The checklist was conducted and the lens was verified with the surgical nurse. The surgeon did realize that a wrong IOL, the monofocal, was inserted, but made the medical judgment at the time of surgery that explanting the lens could harm the eye. Reasons for that: the capsular bag was shown to have mild zonular weakness, and there was considerable posterior pressure bowing the capsular bag forward. Explanting the lens could risk posterior capsular tear, eliminating the possibility of using the planned lens anyway. The surgeon was also concerned about a retinal tear secondary to the eye being myopic and post-LASIK treated. So the surgeon decided it was best to leave the monofocal lens in place. There is no documentation in this handwritten addendum that the error was discussed with the patient. As surgeons, we know that many times we do make a decision during the case, seeing the anatomy of the eye, to not change lenses or do further procedures or during the time of surgery. So if that decision was truly made intraoperatively, there is nothing wrong with that decision. The ongoing postoperative care presented as follows. On the week 1 visit, the patient noted blurring of the vision in the left eye. Week 5, the patient was seen by an optometrist with blurry vision, but the vision corrected to 20/20. 5.5 months later now, the patient presented again to be seen by the surgeon for a surgical evaluation in the right eye. The right eye vision was 20/40, 3+ NS, consented for cataract surgery, and the lens order sheet reads multifocal lens of 25 diopters. So the second eye surgery was on the right eye, femtosecond with aura, a posterior chamber lens, multifocal as planned of 25 diopters. No complications were noted. On the postoperative visits, day 1, the patient is seen by the insured's partner. Patient complains of blurry vision in the right eye. Week 1, blurry vision again in the right eye. Month 1, patient now sees a different ophthalmologist. Blurry vision continues, and at this time, an IOL exchange is considered. And at 6 weeks, the patient presents for the final visit with the surgeon who is the insured provider. The right eye vision was 20/70, the left eye vision was 20/60. The claim, when first presented, starts with the records request. We all have had these, we've seen them. And then there was a notice of intent to sue from an attorney. The theory of liability read that the addendum added after the second surgery, 7 months later. The insured did not disclose the error to the patient, and that there was fraud and intentional misrepresentation. One might ask, well, what was that? We'll get to that. So, disclosure of error 7.5 months after the error in the first eye, the insured sent an email to the patient stating, your near vision is good despite having only one multifocal lens. A refund check for $1,820 for your out-of-pocket expense is on its way to you. There is no documentation in the medical record, however, regarding the refund or a discussion that the patient was notified of this error. So where does the misrepresentation come in? Well, the patient reports that they discovered the error after the second surgery on the first postoperative day, when the insured's partner stated during the exam that the patient, in fact, had a monofocal lens in the left eye, the first surgery. Patient responded, "I hope not, because I paid for a multifocal lens." At which point the examining doctor said, "Oh, yes, you do have a multifocal lens." And if you can read the caption there, this male patient says, "I don't give a damn what the chart says. I did not have a hysterectomy." So this is a case of what the patient heard at what point and what was perceived as a cover-up, essentially. The defense expert in the case states that the monofocal was mistakenly loaded, but the type of monofocal lens is a preloaded lens. The monofocal lens should have been removed immediately and replaced, and probably not advisable to remove the lens at 13 months. The OMIC reviewer stated that the first surgery included a mistakenly implanted monofocal lens instead of the planned and documented multifocal lens that the patient requested. There's no documentation that the surgeon discussed the error with the patient, and there's no documentation that the surgeon discussed the various treatment options after the error. The refund should have been discussed immediately with the patient versus waiting 7 months. The resolution, this was a clear case of liability. OMIC thankfully mediated the case prior to further discovery, and the case was settled for $150,000.
At this point, I'll take over and discuss some of the lessons learned. Preoperatively, we are starting to see a little bit more of, errors in lens choice, lack of going through a checklist prior to surgery. I'm probably getting 1 call a week now on that. So just sort of to, raise that red flag. Ensure that the lens ordered is the lens that is received and sent to the ASC. Confirm the measurements prior to sending to the ASC. If there are changes to the surgical plan, revisit the consent, discuss with the patient, and document. Use a checklist in the OR to verify the identity of the patient, the correct site and side, procedure, patient, position, IOL, and special equipment. We do actually have on the website surgical checklists. We also have a great example of a video for a checklist for intravitreal injections. It's a quick 2-minute video, and it is on our YouTube channel. Confirm the lens type, power against the medical record and patient prior to implantation. Intraoperative changes in the plan, take care of the patient first, always. Use a timeout to resolve, advise the patient, and always document. The old saying that if it's not in the medical record, it didn't happen. Post-operative considerations, thorough, accurate, timely operative report. It makes good care look sloppy when operative reports are done weeks after. And I have seen it. I've seen cases where there's a complication and the doctor has to send medical records to, let's say, a retina doctor, and the op report is not completed, or, it comes later. And it sometimes is hard to explain. Factual, timely disclosure of error to the patient, objective documentation in the medical record with a clear plan, and a financial resolution. This is another question I do get quite a bit on the hotline. I get it from, premium IOL patient situations, oculoplastic patient situations, which of course can be more subjective. And the question is, if I waive or I refund a fee, am I admitting guilt, or does that make me look guilty? And really, it doesn't. Most physicians want happy patients. And if something doesn't go right, it isn't necessarily your fault, but the patient is unhappy. And there are doctors who call and say, I've already spent 100 hours on this with this patient, and I just can't spend any more time. I'm not going to take the implant out of the eye, but I am willing to give a refund. And if that's the case, just call OMIC and we can put together a release for you. And that sort of finalizes or puts a conclusion on the actual situation. So the answer is, it really doesn't make you look guilty. Should you offer a refund? Contact the claims department if you get a written demand. There is a difference between a verbal demand and a written demand. So claims needs to see it if it's in writing. If it's just a verbal demand, call us on the hotline. If the outcome resulted from an error, waive or refund your fees for all related treatment and clearly explain what fees will be waived and for how long. I have seen situations where the outcome wasn't perfect and a doctor offered glasses for the rest of the patient's life. And that just turned into a nightmare because doctors retire. All of a sudden somebody wants a fancy, frame. So I really think you have to put a start and a stop on it. With that, I'll turn this over to Chris, unless you have anything to add about what I said.
Oh, those are all great points. And you'll hear me say time and again throughout this webinar to call claims, contact risk management. They will help you work through this. And, that's what we have insurance for. And they are truly experts. And each case is different. Some cases they might recommend a refund, some they might not. And really walking us through that patient by patient is important. And the other thing that you alluded to, Michelle, which is also very important, is some patients, especially if there's a complication in the surgical space, they expect a refund on everything. Well, in fact, you're not going to be able to promise them a refund on the anesthesia fees or certain facility fees, et cetera. If they need further surgery, you're not going to be able to promise them the refund from the other surgeon's case. So really contacting claims and working through this patient by patient is definitely recommended and will help prevent further problems down the road, because we all know once the ball starts rolling on these, things can escalate quickly. Great, so we'll move on to case number 2, which is one of a refractive error. So in this situation, the patient was referred by an outside optometrist. There are multiple entries in the medical record indicating that the patient did not tolerate monovision well in the past. The patient wanted to be corrected for intermediate vision, and the plan was for femtosecond assisted cataract surgery in the left eye first, with a target refraction of -3/4 to 1, and the right eye at -1/4. This is the note from the referring optometrist. In this case, we've underlined it to point it out, but clearly states did not tolerate monovision in the past. Sorry, this is from the surgeon, but states referred by the optometrist. And here comes informed consent. They used appropriately a specific cataract and femto consent. However, a key element is not signed or initialed. The patient did not, in fact, document through their initials what lens options they chose. They did sign the document, but without this critical piece signed off on. So the postoperative course for the left eye, post-op day 1, the referring optometrist sees the patient. Post-op day 3, the insured sees the patient. Uncorrected visual acuity is 20/60 for distance, 20/20 near, and the refraction is -1. Explains to the patient that the vision was offset by 1 diopter for reading, and the right eye will be set for plano. Second surgery in the right eye, femtosecond assisted surgery. Post-op day 2, uncorrected vision in the right eye, 20/30. Left eye, 20/25. Doing well, come back in 3 weeks. At the 1-month post-op visit, patient complains of other things, including tearing, burning, pain. Distance vision is blurred, and refractive testing reveals regular astigmatism in the right eye. The diagnosis made was residual refractive error and myopia in the right eye, planned for YAG capsulotomy in the right eye, and then PRK to fine-tune the distance vision. The blurry vision continues. Patient comes back 4 months later, distance vision blurry, no improvement with YAG. 5 months later, no changes. Artificial tears sort of help, not really. Assessment is mild myopic prescription that is bothersome to the patient. Plan, see optometrist for repeat refraction, and then return for PRK in the right eye. The patient never returned. The insured received an intent letter to sue. The allegations were negligent care and treatment, failure to obtain informed consent, and breach of warranty of fitness. Recommended lenses were not, in fact, an appropriate choice for the patient. So what did the patient understand? What was reality and what, in fact, were their expectations? So the patient understood that then the intraocular lenses would correct their vision problems for both reading and distance, and that they would no longer need corrective lenses. They paid $4,500 per eye to accomplish this goal. They understood that their insurance would not cover for the recommended lenses, so they had to pay out of pocket because the doctor convinced them that I not only needed them, but I would have good vision for distance and reading without glasses. So on OMIC review, the chart states in multiple locations that the patient did not tolerate monovision in the past, yet the surgeon proceeded with monovision correction. No documentation was noted to support the thought process, and the patient did not indicate the lens choice on the consent form, which could support the argument that the patient was not adequately informed of their lens choices. The insured opted to settle the matter for a very nominal amount prior to litigation of $3,500.
I will take it from here. Let's discuss the lessons learned. We repeat this a lot. I know you've heard this before. Informed consent, it's actually the oral agreement reached after the surgeon advises a patient of the diagnosis, proposed treatment, risks, benefits, alternatives, and potential complications, and the consequences of refusing treatment. The document that they signed just memorializes the actual conversation. So the conversation really is much more important than the document, but of course the document is required by law. Informed consent should be documented through a note in the medical record always, and a procedure-specific consent form, which is recommended. Informed consent versus the surgical goals. I think this is where we see unhappy patients. We see a discussion regarding the risks, the benefits, the alternatives, but there's sometimes a disagreement or a lack of clarification about what the surgical goals were. For instance, I had cataract surgery and my doctor asked me what I like to do. And I said, I like to play golf. And he said, okay, well, I'm going to, this was back some time, and, multifocal lens were still sort of iffy. It was like 15 years ago. And so he said, I'm going to target you for your golf. And sometimes I think that a patient, at least I'm just seeing this by reviewing cases and reviewing medical records, I think it's very helpful when you actually do document what the patient is trying to accomplish in terms of what they like to do. What happens if you and your patient have different goals and expectations? Nobody wants to turn a patient away, but if you can't come to an agreement just in your, pre-operative visit, I think there's a red flag right there, right? It says that what the patient wants or expects is something different than, you can achieve. Surgical goals and patient expectations. If the patient's goal is unattainable or contraindicated, document the patient's understanding of the likelihood of success, complications, and the impact on their daily living. And or just decide that maybe this is not something or a patient that you can help. Align the goals and the expectations. Assess first, determine the role of the cataract and the vision loss, evaluate the functional impairment and the impact of the cataract on activities of daily living. Ask the patient to tell you in their own words what the surgical goals mean for their vision. Evaluate ocular and medical comorbidities that can affect the outcome of cataract surgery, and then communicate options for near vision and astigmatism reduction, the financial implications of IOL choice and method of astigmatism reduction. We did have a case where the doctor thought the patient was going to have a multifocal toric lens, and the patient found out that having, the additional lens choice was going to create another $500 to $1,000. And so they opted for a different lens, and no one communicated it back to the doctor. So when, the lens actually got implanted, the medical record didn't match what actually got put into the patient's eye. Potential need for post-op glasses and contact lens and whether those are covered. Options if the patient cannot tolerate the chosen IOL, and whether the fee includes post-operative refraction procedures. Document. Findings, recommendations, telephone calls, post-op visits, calls to the front desk. Document. Surgical goals and patient expectations. Be careful with the language. Be careful promising anything. Joe Smith down the street had the same type of lens, had a great surgery, has never had to wear glasses. That's what you're going to hear from patients. And of course, the moment that they realize that they might need glasses, they're unhappy. Be clear regarding the out-of-pocket costs, offer all medically indicated options, and do not give the appearance of upselling. With that, I'll turn it over to Chris.
Great, thanks so much, Michelle. So this third case is a case of misfiled A scans. You probably know where we're going with this one. And it's a case of two patients with the same surname walk into the office. And they both need cataract surgery evaluation, and that's what they're there for. This happens all the time. The patients show up with similar names. Patients can't hear their name, and it's questionable who you have sitting in the chair. And I learned early on, and it certainly takes an extra couple seconds, but confirming the patient's name and date of birth, especially if they're not familiar to me, with what is up on my computer screen with the EMR. And it saves a lot of headaches down the road. So two patients show up. A scans were performed on both patients. Patient shows up, A scans are performed, and patient 2's A scan was misfiled in patient 1's medical record. And those A scan measurements were used to calculate patient 1's cataract surgery. Fortunately, the error did not impact patient 2, just patient 1. So neither the office staff nor the surgeon noted that the patient's name and date of birth were incorrect as compared to the medical record. A timeout was performed in the operating room, and patient 1 underwent cataract surgery using patient 2's A scan measurements. In the postoperative care of the first eye, only the same day and post-op day 1 exams were done in the surgeon's office. The week 1 exam was done by the co-managing optometrist, who was not, in fact, in the surgeon's office. The patient was refracted hyperopic, but this was not communicated back to the surgeon. 2 weeks later, the patient was evaluated for cataract surgery of the second eye. The surgeon remained unaware of the hyperopic surprise and performed cataract surgery on the second eye, again using measurements from the misfiled A scan that belonged to the other patient. Again, neither the staff nor the surgeon noted the incorrect name and date of birth on the A scan in the medical record, in spite of the fact of an OR checklist reportedly being used. Postoperative care of the second eye, the patient in this case was seen exclusively by the co-managing optometrist. The surgeon remained unaware of any problems until the patient returned over 2 months later complaining of decreased vision. So what happened here? The medical record documents the surgeon's discussion with the patient regarding the need for IOL exchanges. The record remains silent as to whether the error was disclosed to the patient. The lens exchanges were performed, and thankfully the patient's vision was 20/20 without correction in both eyes. The OMIC review showed that this was a human error and clear case of liability. There were several systems issues that contributed to the error, including the misfiled A scans and the inadequate safety checks, both in the office and in the ASC. No disclosure done to the patient, incomplete documentation, and their poor communication between the surgeon and the optometrist. The patient demanded $95,000. It was a clear case of liability, and the case settled for $36,000.
I will take it from here, Chris. Risk management lessons learned. Pre-operative protocols. Check test results against the patient information in the chart. You know, this is not the only case we've had of this. I had the same thing happen in a retina practice where 2 patients were same exact name, John Smith. Let's just call it John Smith. And they were right next to each other in the treatment rooms. And the doctor actually went in there and indicated what he was going to do. He was going to give an intravitreal injection. And the patient nodded yes. And it wasn't what they were there for. And the same thing happened in room number 2. So it just sort of goes to show you that, you know, patients can be very nervous. And sometimes I don't even know if they're listening to what you're saying, or, you know, they may be older and have some cognitive issues. which is another reason why this is very important as a population ages, to make sure that you have some sort of a checklist that works for you. If there are changes to the surgical plan, do you need to see the patient again? Do you need to renew consent? New surgical plan must be available in the OR for checklist, document changes to the plan in the medical record. I know of a cataract surgeon who absolutely will not do surgery if the patient changes the lens choice a day before. He said too much risk of error that can occur at the ASC, and he just won't do it. And he tells his patients that too. Co-management guidelines confirm that the co-managing optometrist is qualified to co-manage surgical patients, knowledgeable about the complications associated with the type of co-managed surgery, prepared to contact you promptly about complications or delayed healing and to immediately transfer care, and committed to honoring patient requests to obtain care from you. And it's probably a good idea not to only work with one optometrist for fear that there could be some allegations that you are violating Stark law. So you want to make sure that you're using different physicians as referrals. Last case. Back to you, Chris.
Thanks. And back to that previous point, and ACE, it not only applies to ACE scans, but also any testing that goes into the electronic medical record. Sometimes in that transition between machine 1 to machine 2, something happens in cyberspace, and the wrong patient's information, whether it's a visual field or photo or OCT, gets into the patient's chart. So especially noted when you see a normal exam, normal looking nerves, normal pressure, and you have a black visual field staring back at you on the EMR. That's a clear case to check the patient's name and date of birth and compare it. But there are other much more subtle ones, unfortunately, and making sure that we run our own checklists, even in clinic, for basic routine things like any test that we do, making sure we're reviewing it for the appropriate patient. The final case, you might say, who does blocks anymore outside of the retinal space? But the point of this case is more about after-hour phone calls and how that process is handled. So let's push the focus on that. So the insured performed uneventful cataract surgery in the left eye, and the patient presented 1 week later for cataract extraction in the right eye. The procedure at the ASC was done with a nurse assisting in the surgery, and the peribulbar block was done with monitored IV sedation by the CRNA. The operative report does not mention any complications. The day of surgery, the patient left the PACU at 10 a.m. and then the PACU nurse tried to call the patient at noon to do the post-op check, but the line was busy. At 5 p.m., the patient calls the office and speaks to COA, a certified ophthalmic assistant, and reports pain in that right eye, headache, and the insured's instruction by the COA was to remove the patch, start the post-op drops, and use Tylenol number 3s for pain. At 7 p.m., 2 hours later, the COA calls, the COA who's at the office calls the patient, who still reports that the eye is painful, but now it's swollen shut and appears black. The insured's instructions by the COA are to use cool compresses, elevate the head, no activities, and call with any changes. At 9 p.m., the COA decides to call the patient back and has the patient come in early the next morning for evaluation instead of later in the day for their routinely scheduled post-op visit. On post-op day 1, ongoing pain, headache, swelling, can't open the eye, periorbital hematoma, and a pressure of 25. No vision is recorded. Diagnosis is IOLOU, and the plan is to start Xioptin drops and return in 2 days. Post-op day 3, the patient comes in, the retina is documented as flat, the vision in that right eye is light perception, and the patient's referred to retina. The final diagnosis by another doctor at this point is optic neuropathy of unknown etiology with the final vision of no light perception in the right eye. Legal action. The patient filed suit against the surgeon and the practice. The patient's demand was $1.5 million, and the case settled for $750,000. And realize when we talk about these settlements, some might seem minimal, some might seem like more. None of these include all of the physician time and energy and loss of income and such that is in addition to whatever the settlement price was. The plaintiff's expert states that the vision was salvageable until midnight the day of surgery. And, we can question that timeline, but that was what the plaintiff's expert opined. The insured failed to respond to an ophthalmic emergency. The patient had significant pain and swelling, and that was indicative of a hemorrhage that required immediate examination and treatment to relieve the pressure on the optic nerve. And this failure is what caused the permanent vision loss in the right eye. Emergency surgery would have saved the vision in that right eye per the plaintiff's expert. The defense expert notes poor documentation of postoperative visits, no sense of urgency or clear plan with the declining vision until that third postoperative day when the patient is finally referred to retina. Retrobulbar hemorrhage should have been suspected as of the 5 p.m. call, secondary to the swelling and the black discoloration. The insured should have seen the patient based off of the information on the 5 p.m. call. As far as causation, even if the patient was seen following the 5 p.m. call on the day of surgery, it's uncertain based off of the documentation that we have if the vision could have been improved. The OMIC review is consistent with the defense expert opinions.
Okay, I'll start with the risk management lessons learned here on the last case. Chris, I do have one question for you, just because I'm getting a lot of calls about this. Do you use CRNAs?
In some of the surgical centers, yes.
And does anyone ever ask you to sign a form that says you're supervising the CRNA? You ever seen that form?
I have not personally been asked.
Yeah, we're starting to get more doctors that are being asked to supervise in the event of an emergency because there are no anesthesiologists in the room. Okay, documentation of post-operative visits, exam findings, diagnosis, and plan. Demonstrate medical decision-making. Plan and timeline is crucial in cases where loss of vision is occurring or a significant risk. You need to be careful when you are documenting your medical record that there isn't the appearance of trying to cover something up, meaning it's really great, especially in situations like this where your records are real time, because obviously time was of, very critical in this case. Sparse notes may be construed by a jury as indicating a physician who was rushed, not thorough, or unknowledgeable. Develop protocols for telephone screening. We do have on our website and on our YouTube channel a great video and a great document on the website regarding telephone screening. And I encourage practices who I know are going through a lot of staff changes, turnover, or having difficulty, keeping some of the same people, to use some of these resources for training materials for your staff. And I've been told that, people don't even know they're out there. So again, if you go to Ophthalmic Mutual Insurance Company on YouTube, you'll see the video. And if you just type in on the OMIC.com website, telephone screening, you'll actually see the document. Develop protocols for office hours. How are the patient complaints and urgent calls triage? When do physicians want to be interrupted? After hours calls, consider training and the experience of staff, whether a certified technician is actually the person who should be speaking to a patient who has a complaint, such as the one that we just talked about. Special handling for calls regarding post-op complaints. And of course, this is my co-presenter here over on the right in her early days. Patient telephone screening form. This is the form that I'm talking about that I think could be very helpful for training. And you can easily download this. And it really just kind of its own little checklist, actually. And this was another document we put together. I think Ann Menke originally put this one together, and it discussed routine, urgent, emergent, different types of complaints and where they fell and how they should be handled. And again, this is just a great training tool for staff. We have a lot of additional resources. We have over 100 procedure-specific consent forms on our website. We have cataract surgery recommendations, telephone screening recommendations, ophthalmic surgery checklists, and we also have AAO guidelines for surgical co-management, all of which I think you will find very helpful. With that, if you are watching this video, you are qualifying for your risk management discount, which will be processed. If you have any questions, feel free to reach out anytime to riskmanagement@omic.com and or the 800 number. And again, you can find all of our online resources at omic.com under the umbrella of risk management. I want to thank Dr. Albanis for presenting with me today. We hope that you enjoyed the course, and we look forward to speaking to you again soon. Chris, any closing remarks?
Thanks so much, Michelle. And once again, encouraging everyone to reach out to the risk management hotline as soon as you're concerned about anything. And the sooner you talk to them and they help walk you through things, the more reassured you'll be on an action plan. And one more point on consents. I love OMIC's informed consent for refusal for care. So I would encourage you to use that for patients who are refusing care that you deem recommended for them. Sometimes we think they won't sign it, but in fact they do, because they simply don't want the care, but that helps cover us. And in those types of patients and ones who simply are non-compliant for other reasons, I also code the non-compliance codes through the ICD-10 coding. There's several codes on that. But another pitch for Michelle and her entire risk management team at OMIC. Thank you for all that you do for us as physicians, and makes our lives much easier when we know we have experts on the other side helping us guide us through these challenging cases that we think would never happen to us, but sure enough, things happen, and OMIC is there for us. So thank you all for your attention, and thanks for all that you do for patients. Thanks, Michelle.